Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. We are so excited to bring you this episode, led by Dr. Alan Jurim, Director of Digital Dentistry at Toro, a colleague, a friend. He is an amazing dentist with his unbelievable engineering background, and he makes so much sense as it relates to that whole digital workflow. So I'm so excited for him to show his case. We are supported by specialists, very special specialists from all over the country. Dr. Rick Robley, orthodontist from Fayetteville, Arkansas. Stanislav Amishi from Boston. Dr. John Kim from Rocky Mount, North Carolina, periodontist. Stanislav is a prosthodontist, myself, prosthodontist, New York. And we're going to be weighing in and really giving our point of view from our lens and from our own specialty. And we can't wait for Alan, Dr. Alan Jurim, to present. Please, Alan, take it away.
Thank you, Jonathan. Thanks, everybody, for joining us here with this Case Bites presentation. So this case, I want to share Cindy's case. And what was interesting when we began with Cindy's case is she's one of the few patients who came into our practice with the requirement of wanting to have a perfect white smile. And when I say that, part of our initial conversation with the patient is always to try to understand and visualize where they want to go. And this is one of the most recent cases where a patient was very clear. They always said they dreamed that they wanted to have a perfect white smile. And one of the main contributing factors to the change in her mouth has to do with some of the occlusal wear and some of the other parts of the case that we figured that we need to address. So what I want to share with this time together is a little bit of how we looked at this with our interdisciplinary approach and how we tried to figure out the answers to the most basic questions that the patient's asking us. What should we do? How long is it going to take, and how much is this going to cost in order to get the results that I was always, expecting, and what they really came to us with their dreams. So as part of the medical history, there was really no significant findings. Cindy did bring to us a copy of a recent set of radiographs, and in our new patient visit, we'll always work and focus on capturing as much data as possible. And capturing that data is what's very valuable for us in order to try to put together that proper analysis of all the information. So with looking with our cone beam scan, we began to see and identify some of the issues that we thought are going to be significant in Cindy's case. For example, in the upper right, we're seeing that we may have a possible failed endo, same thing on the lower left-hand side. And we can see that we are visualizing some bone loss in some critical areas. And this is one of the biggest complaints that Cindy had when she first came in, was some of the spacing that's developing in some of these areas. And so with our digital analysis of just capturing a lot of the information, we begin formulating what we think is going to be the ideal plan. And then we're going to work with our team through perio, through pros, with ortho, with endo, and how we're going to properly share the data in order to do this best analysis so that we can present to the patient what we believe got her here, and then what we think is the best way in order to treat it so that we don't end up in the same area and we address some of the chief concerns or complaints that the patient was looking to achieve. The most important digital data sets that we have are going to be intraoral scans. It's going to be the photography, and it's going to be the 3D X-ray. And one of these tools is, the ability to see through the tissue, and that's the 3D X-ray. And we're going to use that as a powerful tool to help us analyze what we think we need to do in order to achieve a good end result. So let's look a little bit as to what we needed to do in order to achieve what we believe was the best end result in a case like this. So again, Cindy came to us and she said that she wanted, I put that in the wrong area. She wanted to have the whitest smile that she can have. That was her requirement. She said, I've wanted this my whole life. I'm ready. And so as we go through this process, that's one of the first things that we need to analyze as part of our treatment plan generation. So with our facial analysis and with the prepper photography, we begin taking all this information, and with the patient, we begin analyzing this in real time. And so we can see some of the important factors and some of the things that we want to correct. And we now are going to use a lot of the analysis tools in order to try to share this with the patient. So as we go through this digital smile design and the aesthetic evaluation form worksheet, what we're really trying to do is work in reverse. We're going to try to use the digital tools available to us to visualize that final output, confirm that that's what the patient is always visualized that they want to look like, and then use that information to reverse engineer a plan. And then we're going to judge and we're going to base that plan off what we think is going to be the most predictable outcome for the patient, ideally what's going to be conservative, and what's going to be the longest term prognosis as part of that case. So we knew for Cindy that one of the things that she wanted to do was have a super white smile, and she wanted to show more because she felt like her teeth were wearing away. And in this analysis, we begin with this key image here, which is our 2D smile design. And to now figure out if this is what we believe is going to be a good aesthetic result, well, what do we have to do now in order to make this a restoration, a plan that is going to be with Cindy, ideally for the next 30 plus years? So we're going to try to reverse engineer some of the solutions. Are we going to just add to the incisal edge, or are we going to try to do crown lengthening? We already know that if we want to do crown lengthening, that there are some concerns because Cindy has already had some bone loss in these areas and has been treated for that. So we're going to begin taking all this information and we really put it together into that 2D smile design. And that's the beginning for us, is to do the 2D smile design and then use that as the tool to then enhance and motivate the patient into trying to enhance the plan and to figure out the 3D design. And once we have this information, we're going to do our visualization of 3D where we're going to build in form and function. And you see there, we're also able to take the cone beam data or the bone data and use that as part of the analysis to, okay, if this is where we believe the teeth should be, and this is where we want our new margins, this is where we need our new incisal edge position, what is the bone going to be underneath there, underneath the tissue, and how are we going to manage that, and how are we going to manage the forces afterwards to make sure that we don't have any long-term stability issues with the case. So we do a motivational mock-up. We can try this in, and here we can get a very good visualization with the patient as to some of the changes we want to make. And by using that 3D data of the analysis of where the bone is and where we want our new margins to end up, we can create all sorts of digital planning guides that will allow us to even assist in an aesthetic crown lengthening or in a gingivectomy. And so an analysis like this, where we have all the data aligned, becomes very valuable for us. In fact, we can see here that we have from our new CEJ, the digital smile design to the bone, approximately 2.8 or 2.18 millimeters. And so it begins to be another valuable tool to have everything aligned for us. We'll then use that in order to influence the case. And as we're now understanding where we need to end up, this is the time where we're now speaking with the periodontist and we're speaking with the team as far as an implant that's necessary in the lower left. We're talking with the endodontic team about, retreating several of the teeth, which we think have a better long-term prognosis for retreatment. But really, we're now able to finalize the treatment plan because now we know where we need to end up. Now we know where we want to end up. And as we finalized the case and we executed, what we ended up doing in this case is we did use that smile design with a more ovate edge to create, single units anteriorly. We did some nice porcelain buildup, and we delivered the case on the maxillary arch. And then as we followed through on the lower, we know that we had to place an implant in the site of 19, and we had to manage the force. And so we create a digital bite splint on the maxillary arch that's going to help try to protect the occlusal forces. We know that there's been bone loss around the areas of number 10 and number 11. We're going to try to manage the forces in order to allow us to create a scenario that's going to last long term. And with the periodontal planning with the team, it was decided that the best time to do a connective tissue procedure in order to try to thicken the tissue around this area would be actually after we have the final units in place. So the final units were placed in the maxillary arch. We had a transitional fixed partial denture on the lower left, a 3D printed splint, as we did implant therapy. But we're able to manage the sequence so that the patient is able to understand where we want to end up, realize the value behind doing it the way that we're proposing, which fundamentally should create a scenario that's going to restore the patient's ideal visualization of where they want it to always be, and it should last long term for them. So this is a great opportunity, I think, for us to be able to discuss this case and to see a little bit more about that interdisciplinary approach. Let's take it back to the team.
Well, thank you, Dr. Alan Jurim. I'm just going to throw it out to the group. Just a beautiful case, and love the whole bring it to current day technology and beyond. So that's very exciting to see what's possible in this wonderful world of digital workflow. But I'm going to throw it out to the group.
Thank you, Dr. Jurim. That was a great case. Really beautiful lady with quite a bit of wear on her anterior teeth. I see about probably 40% wear of her incisors. So do we have any idea about the etiology possibly on that?
The wear, I mean, she has never even been aware that she was wearing down her teeth, and she's never been treated for that. And so fundamentally, the idea is let's manage the forces and let's put her into a bite splint before we even provisionalize or prepare any teeth. We were going to alter her vertical dimension. And so we wanted to use that as a powerful tool to try that new position before we do anything permanent, and also make sure that she's a compliant patient where she understands the responsibility for her to manage the forces moving forward. So we would have never even considered restoring these teeth the way that we did before we confirm that the patient is able to manage how she got here and prevent that from being a scenario in the future again.
Thank you. Yes, we're very lucky in prosthodontics that we have the option of testing before we can deliver final restorations through the provisionals. In many areas in medicine, they don't have that luxury. So I consider myself very lucky to be able to check how patient can function and look with the provisional restorations. So I'm not sure if I missed part of it or not in regards to any habits or anything medically that maybe contributed to that. From functional perspective, maybe possibly some violation of the envelope of function, I may add, due to the slightly retroclined anteriors, and maybe she is being violated during her function and wearing down those incisors. But beautiful, beautiful case. Thank you very much.
I'll say that this is a great case to share, and I'll say that what a lucky periodontist you have. It's a dream for us as surgeons to have the guide that you provided. It makes the crown lengthening procedure, I think, a lot more predictable. With that guide, it's not as hard to make the correct gingivectomy and then do the bone reduction or the osseous reduction accordingly after that. So that is just awesome how you did that. I was curious, how soon was this temporized relative to the crown lengthening procedure?
She actually wasn't temporized when we did the crown lengthening procedure around there. We actually had the final units in place, and then we had determined, because we have done several cases where when we make CAD/CAM provisionals, I like to think of them more as prototypes. They fit like a final restoration would. And because of that, we see improved gingival healing. We see a better gingival response, and patients who are able to clean better and have better fitting provisionals normally will have a better, experience healing with their periodontal surgery. In this case, because, the surgeon decided that as long as we can first prove that we can manage the occlusal forces after we had the final units in place, then they would come back and they would want to do the periodontal connective tissue graft there to thicken the tissue. It was determined that final units will fit better. It's in a relatively non-aesthetic area because the patient here has an exaggerated smile, but typically doesn't show much of that area. It wasn't a concern for her in the past. So we did the procedure for the connective tissue after the final units were in place. Normally we would do it in reverse with a printed provisional, something that fits like that. But we determined that in this case, that probably wouldn't last long enough for it throughout the healing period. So we either had to do it before or after the final units were in place.
A lot of times we're doing PMMA provisionals. We'll do a first set of provisionals, scan, and then off of the preps, we're fabricating, PMMA provisionals for, especially the cases that are implant supported or going on for months and months. Fully agree. And digital dentistry is fantastic for that. Absolutely.
Yeah.
Well, an amazing patient, an amazing and a beautiful result, showing us what, kind of the digital workflow can look like, all the way from exciting the patient, saying, wow, when do I start? And being able to kind of power through, whether it's perio, whether it's a lot of restorative pros. Pretty terrific, pretty terrific outcome. And I know that's one happy lady. So congratulations.
A couple quick points here for me. Okay. Beautiful case. I love the technology. I'm all in on that. And a couple important points. Everything's positive. I think it's really important to find out what the underlying problems are. Okay. And in this case, some of the issues that rose to her problems, are not the problems, they're symptoms of other problems. And so we got to make sure that we're doing that. And plus, in fact, I'm going to add a little bit when I present a little bit about the fundamental components treating the problems, just to add to this. This is a beautiful case. And I think technology is amazing, and you're certainly harnessing it to the greatest capacity, and just a beautiful result. So my congratulations to that.
Yes, to that point, I may add that maybe one of the additional evaluation could be, of course, I'm not sure. I'm sure you already did it through your screening, but maybe evaluate her for any airway obstruction. We know the correlation between bruxism and airway, and just being able to approach the case a little bit, probably expand more medically, if that maybe is not the case in this particular patient, but for other patients, just to keep into consideration. Tooth wear, airway, maybe we need to investigate a little bit more.
Exactly. I think she is a classic upper airway resistance patient with appropriate symptoms for that. So I think that's very good, a very good addition to this case.
So what's the normal routine, or what would you recommend in order to test for that? It would just be to speak with the primary physician.
You need like 4 or 5 questions in your questionnaire to bring it up. Okay. Mm-hmm. And you need to know the basic signs of these type of disorders. And usually the problems a patient comes in with are not the primary problems, they're symptoms. And if you go to the physicians and a patient like this, they're going to get an airway study and they're going to say they have no problems, they're completely normal. And that is completely wrong, because they're looking for apnea problems. This patient does not have apnea. She has upper airway resistance. And that's on the continuum. That is where it starts. And it probably started when she was a young lady. It'll eventually develop into apnea. But the way physicians treat it, it's like saying you have a cancer and I'm not going to treat it till it's, stage 3 or 4. And you can do so much at the same time you're making this lady beautiful, that it's just an incredible part. But it's all done with questionnaires and your own testing. You can't rely on the medical unless it is an apnea problem. Then you have to medically.
Yeah. This is such a big conversation, but it's so great we're bringing it up early. But really, it probably takes 40 seconds of questioning the patient.
Absolutely.
The CBCT that you're looking at airway, plus you look in the mouth, and there's 4 phases of this Malapati where you see where the palatal-pharyngeal tissues are uvular. If it's way down the throat, type 4, all the way up like a young person, type 1, 2, and 3 in between. And that upper airway restriction is going to be figured out just by hearing the answers of the patient. And when you say, do you have a sleep problem? Oh, no, I sleep fine. And then you start asking a little bit deeper. And you know what happens? Oh, yeah, my husband said this, or I wake up and I'm not that clear-headed, and you start digging in a little bit more. This type of ailments, connecting the dots between dentistry and medicine, But we're going to talk a lot about this because it's really coming to the forefront of dentistry and especially of all of our specialties. Really exciting path for us to help our patients. Well, anybody else with some closing thoughts?
Well, just to finish on that thought, one more time, I consider we're very lucky in our field because usually by expanding the arch, proclining slightly the teeth, giving the patient better aesthetic, a wider, bigger smile, we're also helping with more tongue space and more overall space for the airway. So in a way, things work very favorably for our specialty and for the patient.
Okay, I'm going to round it out. Hey, everybody, amazing conversation about how do we meet the needs of our patients, improve their smile transformations, but also looking structurally and the idea of keep asking why, not just treating symptoms, but understanding the underlying root cause of how that person got there. That is at the essence of what we can do diagnostically. Case Bite strikes again. Great being with everybody. See you next time. Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.